to fill up this pipe that has the holes in it is called neovascularization. So these new cells that the body creates to create new pipes to take the blood and the nutrients to where it should go, they are abnormal and they will fall apart and they leak even more.
And so this is all happening in the retina, which has a bunch of different layers.
Right.
And any bleeding or any new blood vessels that are forming are going to alter the transmission of light in the retina. Is that how,
yes.
how it impacts
So what happens? Yeah. What happens? We have 10 layers of the retina, and the blood vessels that leak are the upper third of the retina, closest to the vitreous, the inside of the eye, and closest to where you could bleed right inside the eye and lose vision quickly. So when they bleed, they leak blood through the retina into the vitreous. So it fills the vitreous cavity, which is optically clear, like a gel, like Jell-O. So instead of being clear, it's filled with murky blood. And that's why you suddenly lose vision. When a diabetic will say, I was seeing fine, and suddenly I lost all the vision in my eye. So what happened in that case would be, presumably there was leaking in all the other areas slowly, but it did not reach a critical point where it broke through the retina and leaked into the vitreous. And once it does that, all the dams break forth, and then you just get huge torrents of blood. And then what is then the possibility for the patient is, if it's a very bad hemorrhage, they would then need to have something called a vitrectomy, where we would put instruments inside the eye right here, small instruments about the size of a needle. Inside has a mechanized knife that's controlled by a foot pedal that sucks up the blood, eats up the clots, and then you're cleared again. So your vitreous will then be removed, replaced by saline, and the person will then have laser at the time of the operation or shortly thereafter.
And is that all done in the office?
That would be done in the operating room.
Okay.
So if the vitreous hemorrhage is not so bad, that it's not filled with blood, but we can still see, we would start lasering in the office, put them at bed rest, and now we would try and give them something called Avastin, which is also called bevacizumab, which is a monoclonal antibody which you would inject inside the eye and would treat what we think are the release of vascular endothelial growth factors and would block the bleeding on a molecular level.
So, that will that replace all the laser work that you do?
This drug is not FDA approved yet. It is used off-label, but has been used by retinal surgeons across America for the past 2 years, because in smaller studies, not the giant ones which have 5,000 people in it or 100,000 people involved, we have found a 70% increase in vision with the use of this drug.
Is that in conjunction with the standard surgical therapy?
This is standalone if it's a very mild vitreous hemorrhage or very bad macular edema or just early proliferative diabetic retinopathy where it's not frank bleeding but just little abnormal blood vessels all over the retina. And it's also in conjunction at the time of surgery, a week before surgery, and after surgery.
So is that something that a diabetic should take before they get disease?
Nobody's ever thought of that. One of the reasons that we have not gone to that process of thinking is that because this drug is not FDA approved and we're using it off-label, we have no clinical trials yet. There's one that's being formed right now called a CATT study, and we'll have the results in 2009.
I imagine that's fairly expensive therapy.
Now, there are two types of this drug, all made by Genentech. One that is approved called Lucentis, which is called ranibizumab, and the non-approved one, which is Avastin. The first one, Lucentis, is approved for age-related macular degeneration only. And for us to use Lucentis, it would cost $2,000 for a diabetic, and that is now not approved by any insurance company. So Avastin is significantly cheaper, $100 to $150, and that can be paid out of pocket by the patient if it's not covered by insurance. In some states, both are covered by insurance, but not in California.
So when patients come to your office, they've are sent usually because they have eye symptoms already, but hopefully they've been seeing a eye care specialist to identify early disease.
Yes.
But when they get to your office, they already have probably symptomatic disease.
Yes.
And then at that point, the options are what again?
The options are just treating their fasting blood sugar, because it could be very minimal, and we can give them eye drops, and we'll give them diagnostic aids such as an Amsler grid, which is essentially a black and white version of graph paper where you stare at the center once a week with one eye covered and see if anything's missing, or laser immediately that day, because their macula may have little leading points of blood where it tells us that's where the leakage is, and we would laser immediately, and we would use 100 micron spot size, so it's very small. So that would be the diameter of 10 hairs, so it's a very small spot, and that they would not see any little dots or any little distortion in their vision. They would, in fact, improve their vision from 2 to 6 weeks, in 2 to 6 weeks. And the other thing to expect is more sessions of laser, where you would do the first session that day and come back for 1 or 2 more sessions. And then lastly, if they are filled with blood, we would laser immediately, give Avastin, or give Avastin that day and then laser later on in the week. Or then if it's filled with blood where we cannot see it all, we would suggest over a few weeks after watching them vitrectomy surgery, where we surgically remove the blood.
So what would be some take-home messages for our audience today?
Take-home messages are that, number one, take care of your diabetes, that make sure that you know what your fasting blood glucose is, know what your hemoglobin A1C is. Hemoglobin A1C means it's the how much glucose is on each hemoglobin molecule. So that's measured.
So it gives you like an average over
yes,
a long period
over
of time.
6 months. And it's in a percentage. So it's 6.0 is perfect. People who don't have diabetes will never have it, will have hemoglobin A1C of 4.5, 5.1, 5.5, but 6.0 is what we aim to shoot for. Some people with diabetes have 7.0, 8.0. 8.0, if you wait long enough, within a year, you will have eye disease, and we don't wish that on anyone. And the second thing is see an eye care specialist, an IMD, an ophthalmologist, to have some baseline exam, and see a retina specialist if you have further questions. We're all reachable.
Well, that's been a very, very insightful discussion. It seems like the key to this disease is not to get the disease, and to have your diabetes treated aggressively and controlled, and then that way you'll have more free time.
Right, and have good vision.
Yes. Well, it was a pleasure having you today, and I hope that you can return and maybe discuss some other aspects of your practice.
Oh, thank you.
Thank you.